Hey everybody, this is Mrs. McDaniels. We're going to talk about valvular heart disease and inflammatory heart disease. I do have some other recordings of this presentation from past semesters, and if you've seen some of my other videos online, you should be able to find them all on my YouTube channel that I keep up pretty active of past semesters. So if you don't like this one, you can listen to another one. It's probably going to be just about enjoyable of any of them that you actually take the time to listen through. So let's get through valvular heart disease and hit some highlights. So valvular heart disease obviously is going to be a disorder that's going to affect the valves of the heart. Left side or right side. Left side is going to be more common, obviously, because we are dealing with the side of the heart that's actually going to push fluid and the blood to the rest of the body. Different classifications, make sure you know your terminology. We have stenosis, which is a narrowing that impedes blood flow moving forward. Regurgitation or insufficiency, those terms are used interchangeably. That's basically when some blood flows backwards versus just continuously moving forward. So I call that like the 2 steps forward, 1 step back. Etiology, where is it going to come from? What's the root cause? Can be anything from born with it or it is acquired. Degenerative can be damage over time. Rheumatoid, as I said in class, when you hear rheumatoid, always think autoimmune. We're going to have some changes that will cause damage to the valves. Or infective endocarditis. This is actually an infective organism that does damage to the tissue. So if we're thinking of internal aspects, autoimmune, external, think infection. Some risk factors for valvular heart disease: hypertension, rheumatic fever, which is basically an inadequately treated strep throat or scarlet fever. This comes from the streptococcus bacteria, infective endocarditis, and some congenital malformations like Marfan syndrome, which is a problem of the connective tissue. And age can also cause some issue. Older clients, degenerative calcifications and atherosclerosis can also influence how the valves work. So some expected findings of valvular heart disease. You may hear a murmur. You don't need to know exactly the different types of grades of murmurs or where you're actually listening to, but just know that a murmur can be associated with a valvular disease. Also, most patients are typically asymptomatic until the later stages of the disease process itself. Findings of valvular heart disease, again, if we're focusing on the left side, which is more common, you can see increased pulmonary artery pressure, left ventricular hypertrophy, and a decreased cardiac output, which can result in orthopnea, paroxysmal nocturia dyspnea, and fatigue. Make sure you know your terminology. Orthopnea is basically a shortness of breath when you are laying flat, versus the paroxysmal nocturia dyspnea is basically a shortness of breath that will actually wake somebody up in their sleep. Again, I think this is slide number 3, that I'm emphasizing that most common is going to be left-sided valvular disease or damage. So there is typically mitral valve involvement, could either be stenosis or insufficiency or regurgitation. Know that atrial fibrillation ends up being one of the symptoms, and it can result from a strain on the atrium. Also may see pulmonary venous hypertension that will decrease the ejection fraction as well. So make sure you know your atrial fib symptoms, irregular and rapid heartbeat, heart palpitations, or rapid thumping inside the chest, dizziness, sweating, and chest pain or pressure, shortness of breath or anxiety, tiring more easily when exercising, and sometimes syncope, which is fainting. Miscellaneous disorders, valve prolapse. This is basically where you see kind of a parachuting when the valve closes. There isn't regurgitation or anything. Most patients are asymptomatic. Over time they may develop some symptoms, but normally, again, may have a murmur. But treatment is usually nothing if they're asymptomatic. Symptomatic patients, you're kind of treating the symptoms. So it could be beta blockers, calcium channel blockers to relieve the chest pain and palpitations just from the irritation. Eliminate caffeine and alcohol to also reduce those symptoms. And you want to educate your patient about reading over-the-counter drug labels. And the big thing is just teaching patients about maintaining a level of function and managing their symptoms. Having mitral valve prolapse doesn't put a patient at risk for infection, ischemic heart disease, or effusion. Another issue that might come up, you may have seen this in your peds class, is aseptic wall defects. It's an abnormal opening between the left and right side of the heart, which can cause oxygenated blood to be shunted from the left side of the heart, where there's greater pressure, to the right side, where there's less pressure. Most defects are typically congenital and will be repaired in infancy or in childhood. If a patient has a patent foramen of Vail, a PFO, it's a small atrial septal defect, or ASD, which can actually go undetected until somebody has a transient ischemic attack, or a TIA, or a cerebral vascular accident, which is a CVA. And you can see here the opening. In normal vasculature, if that wasn't there, a clot can typically be filtered out by the lungs, but because of this opening here, it can actually bypass the lungs and go directly to the brain, which unfortunately can lead to a stroke. So it kind of explains where the stroke can come from. Atrial fibrillation is typically common, and patients who have that are going to be at high risk for stroke. Because remember, again, in atrial fibrillation, if the heart is quivering, you don't have the same movement of the blood, and so you can have some stasis, which can lead to clot formation. Closure typically can be done percutaneously with ASDs, but not VSDs unless there are signs of endocarditis or compromised valve function. Patients need at least 6 months of prophylactic antibiotic therapy to prevent infective endocarditis. This box here is just something to kind of think about, that an ASD creates left to right shunting that can lead to right-sided heart pressure and pulmonary congestion, which ultimately results in right-sided heart failure. Cardiomyopathies, this is when we're looking at the mechanical electrical dysfunction in the heart. It's best detected by an echocardiogram. Best thing to do is to help decrease the cardiac workload. Start off with bed rest and increase activity slowly. Medical management is typically done first, but heart transplant is usually a last resort if medical management is no longer effective. Diagnostics, for valvular heart disease, we'll see a lot of crossover of these diagnostic tests in some other the cardiac disorders, but chest x-ray shows chamber enlargement. Your EKG can show chamber hypertrophy. Your echocardiogram can show chamber size hypertrophy, specific valve dysfunction, how well the heart is pumping with ejection function, and the amount of regurgitation flow. Exercise tolerance test or stress test will see the impact of the valve problem is during stress. Radionuclide studies determine the ejection fracture during rest and activity. Again, that will come up later and some of our other conditions like coronary artery diseases. In angiography, we'll look at the arteries to the degree of the atherosclerosis. So sometimes heart catheterization might be used as a diagnostic tool in vascular disease as well. Medications to treat valvular disease, we're going to see a lot of crossover. Diuretics, furosemide, HCTZ, and spironolactone. Furosemide and HCTZ can both cause hypokalemia simply because they are non-potassium sparing. Know that hypokalemia can potentiate dysrhythmias, so make sure you review your signs and symptoms of hypokalemia. Spironolactone is potassium sparing. Those patients could be at higher risk for hyperkalemia, so also know your signs and symptoms for hyperkalemia. Know your lab values for potassium. Patient teaching, those taking loop or thiazide diuretics should consume foods and drinks high in potassium to kind of help counteract that hypokalemia effect. There are a lot of foods that have potassium in them, things that are going to be rich in potassium: dried fruits, nuts, spinach, citrus fruits, bananas, mushrooms, potatoes, and things of that sort. Some other medications used to treat valvular heart disease, your afterload reducing agents. These help the heart pump more easily by altering the resistance or the pressure or the load of the heart. The load that the heart must eject blood against. So this is going to help lessen that pressure and make the workload for the heart less. ACE inhibitors, going to end in pril. You want to monitor the initial dose for hypertension. Angiotensin receptor blockers, your ARBs, they usually end in sartan. Beta blockers typically end in LOL, and your calcium channel blockers end in dapine or dapine. Preload and afterload. Preload, remember, is the volume that enters the ventricles. Afterload is the resistance left ventricle must overcome to circulate blood. Other medications, your positive intertrope agents, they help increase the contractility and improve cardiac output. The drug of choice is going to be digoxin. Make sure you know your teaching points. So, for patients who are self-administering digoxin, count pulse for 1 full minute before taking medication. If the pulse rate's irregular or outside the limitations set by the provider, usually less than 60 beats per minute or greater than 100 beats per minute, they should hold the dose and contact the provider. Take the prescribed dose at the same time every day. Do not take digoxin at the same time as antacids because it will lessen the effect of digoxin. Allow at least 2 hours between the two. And teach your patients about the signs and symptoms of toxicity. Nausea, vomiting is very common. Fatigue, muscle weakness, confusion, visual changes, and loss of appetite. And one way to kind of break that down that I've put together is think stomach, eyes, and breathing. Also with digoxin, watch potassium levels. In states of hypokalemia, digoxin toxicity is actually worsened because digoxin normally binds to adipase pump on the same site as potassium. So when potassium levels are low, digoxin can easily bind to the adipase pump, exerting the inhibitory effects. So low potassium can equal digoxin toxicity. Other medications use anticoagulants. They're for clients who have mechanical valves, atrial fib, or severe left ventricular dysfunction. So why do mechanical valve replacement increase the risk of clotting? Remember, it's treated as a foreign substance, so they're going to migrate to the valve. So people with mechanical valves are on lifelong anticoagulants. Another treatment, they may do a percutaneous balloon valvuloplasty. This is going to kind of help open up the valve. It's helped to treat stenosis, complications, aortic regurg, emboli, valve damage, rupture, perforation of the ventricle. Big thing you want to watch following the procedure is for ventricular arrhythmias. Anytime you kind of agitate the heart, you may see some arrhythmias. Other treatments to help regurgitation, annuloplasty, leaflet repair, or cardioplasty. Now, if valve replacement is done, like I said before, with mechanical, the patient will have lifelong anticoagulant therapy. For those who want to use a tissue base, they don't need to have the coagulants for the rest of their life, but they will need to have valve replacement every 7 to 10 years. Patients who are on the anticoagulant therapy, make sure you know your ranges for PT and INR. So education for patients who have valves. Stress the importance of prophylactic antibiotic, daily weights. That's notify provider of 2 to 3 pounds in one day or 5 pounds in a week. Teach them how to actually weigh themselves. Should be the same time, same clothes, same scale every day. So you want to kind of recreate so you have consistency to know if the weight gain is accurate. Coordinate activities with rest periods. Encourage them to exercise. Dietary restrictions. Avoid coffee and alcohol. Teach them about energy conservation, about taking breaks. Open wounds need to be cleaned carefully, and antibiotic ointments, just so that it doesn't increase the patient's risk for something like infective endocarditis. Fever should be reported immediately to their healthcare professional. Petechiae, rash, or shortness of breath should also be reported. Read over-the-counter labels and try to stay away from medications. Have alcohol, ephedrine, or epinephrine, because that can cause dysrhythmias. Also, talk to patients about the symptoms of heart failure and to make sure to report those immediately. Now we're going to move into inflammatory disorders. Itis means inflammation. Be very mindful of this term and just have a good idea that when you're seeing itis at the end of something, an inflammation, in terms of what are we going to do for treatment. Inflammation of the heart, basically an extended inflammatory response that often leads to the destruction of healthy cardiac tissue. So best thing is going to be through health promotion and disease prevention. It's going to be early treatment of strep throat, compliance with finishing antibiotics. So what typically happens is if somebody is non-compliant treating strep throat, it can eventually evolve into rheumatic fever. Rheumatic fever is going to create this immune system response that will actually start to attack healthy tissues in the body, including that of the heart. Treatments like antibiotics for dental and respiratory treatments may be needed for patients that are at higher risk. Also, make sure patients at higher risk are getting their flu and pneumonia shot. Elderly population in particular. It also helps decrease the incidence of myocarditis. Risk factors for inflammatory disorder. I've kind of grouped these together, like I talked about in class, to hopefully help you remember them better. This first grouping I saw more as internal issues: congenital heart defect, immunosuppression, rheumatic fever, school-age children with strep infections, long durations of strep infections, so things that happen inside the body. This, to me, I group these two together because it's something that is done to the body, so IV drug use, heart valve replacement. This right here is more social issues, malnutrition, overcrowding, and lower socioeconomic status. The first one I'm going to talk about, if you remember that sheet that I handed out in class that showed the different layers, just to give you an idea of the progression of the issues. The pericarditis is going to be a little bit different than some of the other inflammatory disorders of the heart, simply because it has a space, and it has a space between the layers in which fluid can build up, and that's one important thing to remember, and that's what makes it very different from the other inflammatory disorders of the heart. It does mimic the symptoms of an MI. It can happen after a respiratory infection. It can also be due to an MI. Findings: chest pressure, pain aggravated by breathing, especially in, coughing, or swallowing. May hear a pericardial friction rub at the left lower sternal border. Patient may have shortness of breath and fever. Big thing, pain is relieved when sitting and leaning forward. Patient may have some elevated cardiac enzymes and elevated ESR or CRP, simply because these are going to be indicators of inflammatory or inflammation in the body. Your CRP is going to be a little bit more sensitive. EKG or ECG will show an ST segment elevation in all leads, and the echo will actually show the inflamed heart layers. So as you look at it, you're going to find that the treatments for the different inflammatory disorders of the heart are going to be very common across the board. Anti-inflammatories to help with inflammation. It just should not be given to those with a history of MI, because it can actually rupture the infarction. Prednisone will help lessen the immune response. And the other one of these here are going to have a lot to do with what the etiology of it's from. Now, because of that space where fluid or effusion can build, a pericardiocentesis may need to be done to actually draw off some of that fluid. If some of that fluid is drawn off, this fluid here will be sent to pathology to do a culture and sensitivity to determine what type of treatment needs to be done. Position the patient in tripod positioning. It's going to make them feel better, and talk to the patient about limiting their activity. The two big complications that you will see with pericarditis is pericardial effusion, which is going to be fluid in the pericardial sac right here, and cardiac tamponade. Basically, this is going to be compression of the heart from the fluid buildup. So this is going to be a cause and effect. The cause is going to be the fluid builds up, and the effect is the compression. And this can be confirmed by either X-ray or echo. And again, like I said, two major complications: pericardial effusion and cardiac tamponade. When you're looking at signs and symptoms as we go through, especially the itises, you're going to find a lot of crossover. Look for the signs and symptoms that kind of distinguish each one to themselves. So some of it, they're going to have a feeling of tightness in the chest, muffled heart sounds, JVD extension, and this pulsus paradoxus, which is a decrease of 10 millimeters of mercury or more in the systolic blood pressure during inspiration. So you see here, putting a squeeze on the heart. Two complications of pericarditis: effusion and tamponade. Moving to the next layer of the heart, this is going to be the actual muscle portion, which is the myocardium. So we're looking at myocarditis. It can have etiology, could be anything from viral to fungal. Some of the findings: cardiomegaly, because it is that heart muscle, dysrhythmias, chest pain. Echo, you can see the inflamed heart layers. Again, looking at labs, the ESR or CRP may be elevated. The CRP is going to be a little bit more accurate and sensitive. Treatments, again, depends on the cause, and the biggest complication that you need to know is life-threatening ventricular arrhythmias. Alright, so now we're moving into the endocarditises, and we're going to discuss two different ones. We're going to talk about rheumatic endocarditis, and we're going to talk about infective endocarditis, and we're going to break it up, and hopefully you can keep these straight. Rheumatic, remember way back when I said you hear rheumatic, think of autoimmune. Okay, so rheumatic endocarditis basically is an infection of the endocardium due to a complication of rheumatic fever that causes an autoimmune response that attacks the healthy endocardium tissue of the heart, causing permanent damage. So what you have going on here is you have a bacterium that has got into the body, had a systemic effect, and over the course of time, because it hasn't been treated, it turns into rheumatic fever, which the autoimmune response can result into rheumatic endocarditis. So the actual attack on the heart here is not going to be the bacterium, but it is the body attacking itself. And the reason why this happens is it gets to a point where it's not sure, it's like an overreactive response. So some of the results of this is that it can cause mitral stenosis and regurgitation. The damage is permanent. When we see rheumatic, think autoimmune. So the findings, I would kind of focus more on the things that cause joint pain, chest pain, rash. Those are going to be a little bit more different than some of the symptoms of the other itises. So what happens here again, like I said, you have the bacterium that gets into the body. It stimulates this antibody response, and basically the body just doesn't know what is bad and what's not bad, and so it just basically starts attacking its own tissue. So ways to help treat it is prevention, the proper use of antibiotics, NSAIDs to reduce inflammation and lower the risk of the damage, other medications to treat if patients at risk for heart failure. They may need valve replacement depending on the extent of the damage, and they might also need lifelong antibiotics to prevent further attacks of rheumatic fever. Complications, obviously if you have a bacterium, could lead to bacterial endocarditis. Complications of pregnancy and delivery due to the heart damage, and a valve can even rupture. So infective endocarditis is going to be an infection of the endocardium, but this is due to direct assault from an infective agent. So it could be strep, it could be staph, fungal, or some other little organism. So that organism is actually doing the damage to that layer of the muscle, of the heart muscle. So, or excuse me, the heart. So I hope that makes sense, the difference between rheumatic and the infective. I think I went over extensively in class about that, but just hopefully you got it straight. People who are going to be at risk for infective endocarditis are those with structural cardiac malformations, cardiac devices, prosthetic heart valves, or are IV drug users. Those who are doing anything invasive can also increase that risk. That allows bacteria into the bloodstream. So again, those who like tattoos, make sure you're going to reputable places to get your tattoos. This kind of gives you an overview how bacteria gets into the body and actually attacks the heart tissue. The symptoms for infective carditis, this mnemonic from Jane, we have fever, Roth spots, oscillar nodes, murmur, Janeway lesions, anemia, nail bed hemorrhage, and emboli. And we'll go into a little bit more of what those are on the next slide. And you don't need to necessarily know the difference of these, but just know that these are associated with infective endocarditis. Treatment, you need to have blood cultures to determine the best antibiotic or treatment. Here's the big thing about infective endocarditis: several weeks of IV antibiotics. This is just a nice little overview. You don't need to know the Duke's criteria. So time to ponder. Staff educator is presenting a workshop on valvular disorders, which, when discussing the pathophysiology of aortic regurgitation, the educator emphasizes that aortic regurgitation causes what? Left ventricular hypertrophy. A patient with mitral stenosis exhibits symptoms of dysrhythmia. Based on the pathophysiology of this disease process, the nurse would expect the patient to exhibit what heart rhythm? Supraventricular tachycardia. A patient recently received a mitral valve replacement, in which the patient received a mechanical valve. Which of the following blood tests would be most relevant to potential complications? The nurse is caring for a patient with acute pericarditis. What nursing management would help minimize complications? Rheumatic fever significantly increases an individual's risk of developing mitral stenosis. Does chest pain always mean heart attack? Nope. All right. Well, I hope you are doing well, and always got to have an eye on the prize. So if it is a Friday and you're watching this, I hope you have a great weekend.